Hello and welcome to Kickback Science Podcast. I'm your host, Dr. Luke. This podcast is your place to get the tools and knowledge necessary to navigate the world of health and wellness. So kick back, let's talk science. This is good content. This stuff has gone great. We'll jump into it. Let's dive in. Let's do a little science. I'm going nitty gritty science right now.
I've been looking forward to this.
Kind of going on a little bit of a tangent.
Oh yeah, that's right. I forgot about that.
The information we discuss in this podcast is not meant to be taken as medical advice. It is simply informative. We're not affiliated with any organization or institution, just a few guys talking science and having fun. We have Toni Krynski, my sister. Strange, huh? We're talking about sex with my sister. Now, there's a reason, though. Toni, she's a licensed professional clinical counselor, is her license, and she has spent the last 8 years working in the sexual health field. And so she's here to teach us about sexual health. What is sexual health? What kinds of dysfunctions in sexual health can occur? How prevalent are these? What are some resources that are available for people who suffer from these? How do we relate those issues of sexual health to our overall well-being? Because oftentimes I think people consider these things of like sexual health, psychological health, physical health being completely separate. In reality, they're all very intertwined. Yep. So if you're tuning in and you're like, wait, last week's episode was about muscle. Now we're talking about like sex. What is this podcast? Well, I promise you there's a reason we're talking about this. And it really is how relevant your sexual health is to your everyday health. So we have Toni Krynski on, an expert in sexual health, and she's going to share her expertise and talk a little bit about what she does in the field. Also, side note, she also happens to be married to that weird guy in the background that often like talks about how much people can lift with their teeth and stuff like that. The random facts. Joe, our editor, the chief editor of the Kickback Science Podcast. But without further ado, that is my attempt at an introduction of my sister, who really needs no introduction. Is that a compliment? I don't know. I've heard people say that you need no introduction.
I think so. Like people already know.
Oh yeah, you already know.
You already know who it is.
So that's what we're going to be talking about today. Toni, tell us a little bit about your journey, how you ended up here. What is your background, and kind of give us a little framework for what we're going to be talking about.
Sure. So I graduated from the University of Minnesota, go Gophers, with my bachelor's degree in psychology. And then I got my master's at University of St. Thomas, and that was in counseling. And so in the master's program in counseling, your second year, you start doing a practicum, basically like an internship. And I did my internship at Alpha Human Services, which was a residential treatment program for people who committed sexual offenses. So ever since I started my career, I was really interested in criminal behavior and kind of understanding like why do people engage in criminal behaviors, especially sexual offending. So since the very beginning, I've worked with people who commit sexual offenses or otherwise like act out inappropriately. So that's what I've been doing the last 8 years. I worked in the residential program. I've worked with adolescents in an outpatient program who also have acted out sexually or engaged in criminal sexual behaviors. And then recently, we just opened an adult residential program. Hard launch is Monday for our first clients. So that's an adult residential program, actually the only adult residential program in Minnesota outside of the prison system. So that's super cool. Really excited about that. I'm the clinical director of that program. So again, just kind of my special interest area is definitely sexual offending and kind of like understanding people's motivations for engaging in inappropriate sexual behavior, like what drives that and how do we fix it?
That's awesome. So you have spent the entirety of your career in this area of people acting out on these, what did you call them? Inappropriate sexual behaviors?
Yes.
So And you said the prison is the only area for adults in that field until
in residential.
In
so
residential.
there's adult outpatient programs where people can live at home, have a job, they're going to therapy maybe a couple hours a week, group and individual, but residential, they're actually like living in the house. And they're spending, I think it's like 14 hours a week of therapy that we're doing, and it's pretty restricted for their community involvement. So they're not able to have jobs. They can't access internet. It's typically people that are either coming out of prison, and this is sort of helping them to reintegrate into the community safely, or it's like in lieu of going to prison. So people can participate in residential treatment, and if they are unsuccessful, then they may go to prison because it's a violation of probation. Does that make sense?
Yeah. No, okay. It totally does. So before...
I'm in an outpatient program at home.
So if you didn't hear Joe, he's in an outpatient program at home. Joe, you'd be a great client. So I don't want to like dive into too much of, like what do you do with these individuals quite yet? I want to talk about that, you know, like what is your approach to somebody who has committed these inappropriate behaviors, and like what is our thought in the field of, you know, what kinds of psychological issues could predispose somebody and all that. But I think we should come back to that when we talk about like sexual dysfunction. Okay, so before we dive into whatever dysfunctions can arise with sexual health, sexual function in general, and what you do with your clientele and in your practice specifically, let's take it back to, you know, the apparently healthy population. Like, how does sexual health present in like a therapy setting?
Sure. So if you're not me, and if you're not someone who's working with people who've offended, I would say this shows up in kind of general therapy settings in quite a few ways. One being someone going to therapy after they've experienced a sexual assault. That, like the trauma of that and coping with that, brings a lot of people to therapy. Couples therapy is another really big one. So we'll see a lot of sexual health being discussed in couples therapy with like desire discrepancies, and I'll talk about that a little bit later, or just kind of the relational struggles that can come with distress in the sexual relationship. So couples therapy is another huge piece of that. And then sexual dysfunction. So sometimes people are coming to therapy to kind of like work through and cope with some type of sexual dysfunction that they're experiencing. I would say in a mainstream setting, those would probably be a lot of the primary ones.
Do you feel that your field has grown pretty significantly? Like I'm generalizing here by saying like the field of therapy, counseling, I feel like people have started to feel more comfortable talking about their mental health because we know how correlated your mental health is with your physical health. That's something that I've noticed in like the medical field, is it's becoming so much more normalized for you to say like, oh, I see a therapist for whatever issue you might be having, or not even issue. I just see a therapist because everyone benefits from somebody to talk to.
Right.
Now, with sexual health specifically, is the field also growing in that area like it is just mental health in general?
I think it depends. I would say I have talked to a lot of therapists who aren't working in like the sexual health field that have a lot of their own anxieties or insecurities around talking about sex with clients. And I imagine it's the same for medical professionals. You might be worried of like, if I bring this up, how is the client or the patient going to respond? Are they going to be embarrassed? Are they thinking that I'm assuming something about them? So I think there are some fears with like, if I bring these things up when they're not the one to bring it up, what's going to happen? But I do think that like I recently started my own therapy, and as part of my intake process, there was a lot of questions around sexual health, and it was very open-ended, just like tell me about your sexual health in general. And I was like ecstatic to see that. I was like, amazing. Like, because if I wasn't comfortable bringing that up with my therapist, that like intake process before I've even sat down with her made me feel would make me feel a little bit more comfortable just knowing it's an area that can be discussed in therapy. Does that make sense?
Yep. Yeah, totally. When I started med school, we had a sexual health class where we talked about like the anatomy and, you know, different sexual dysfunctions that may arise and the treatments and all that. And then we kind of like, this was early on in med school. And during the course, the professor is talking about how like you have to ask about sexual health to all your patients. It doesn't matter who it is, like bring it up. And it was like, yeah, no, that makes perfect sense. And we went through the training with like hypothetical patients, and we were always asking like, tell me about your sexual history, like, you know, are you sexually active, with how many partners, blah blah blah. And then you get into the actual field, like as I'm like working in the hospital and observing these physicians who've been in the field for a while, like it never comes up. Like nobody's doing it, and I feel like it's like just this like, oh, sex
it's like
is
a taboo
awkward.
topic.
Yeah,
we don't talk about it.
Yeah. Especially here in the United States,
Yeah.
I feel like, you know, you look at other cultures, and I don't know a ton about other cultures, but I do know that sex is a little bit more normalized. And like the human body is a little bit more normalized and like natural. And the reality is like sex is a very natural part of our lives. Mm-hmm. And like it shouldn't be this taboo. But yeah, all the research in this area that I'm familiar with, just from the classes and such, I remember talking about the like survey studies that are done in like, you know, assessing the prevalence of erectile dysfunction, for example. And I remember learning about how there's a huge percentage of people that suffer from some sexual dysfunction, but they don't know where to go.
Yeah.
So it's like, do you talk to your physician? Everyone thinks like, I'm going to talk to my physician about everything. But the reality is like, we don't get a ton of training in this. Like I can screen really well to see if you might have some sort of STI, and tell you about the risks of, you know, having some sort of like trauma to like from like a car accident or something, like, you know, like the anatomy and STIs. But physicians, unless you specialize in these areas, you don't really have much expertise. This is me going on a tangent, Tony. You're going to have to get kind of like comfortable with me just talking. But I bring all that up just to say, like, I've seen the field progress in other areas from an outsider's perspective. But what I'm hearing you say is like sexual health is lagging behind still.
I think so.
Yeah.
I think we need to do a better job just as a culture, as a society, about how we talk about sex and the things we teach. You were talking about like differences culturally. I think one country that I know of specifically that does a really good job is Germany. In Germany, it's mandatory that every single school teaches sexual education. Kids begin learning about sexual education at 9. Like, can you imagine that? Like, I don't think I started getting sexual education in school until I was in high school.
Same.
And even then, the education was so, well, granted, I did go to primarily Catholic school, so it was all based on like waiting until you're married to have sex. But I still think even in the young people that I work with and the sexual education that they're getting in school, it's not fact-based, it's not skill-based. And so in Germany, they're doing a really good job of like teaching how to identify like sexual harassment, what to do about it, which is really cool. Like we don't do a good job of that at all. We don't teach the laws. We don't teach consent. We don't teach people like what to do if you see someone being harassed or assaulted and how to manage that. And we just have a society that has such a negative view of sex. And when we have sex negative societies, we have a very like limited view on what is considered appropriate sexuality. Our education is very limited, and just our communication around it is limited. So if you look at countries like Germany, where they have a much more positive attitude towards sex, they communicate about it openly, kids are being exposed to it. It just creates an environment where like then kids feel comfortable going to adults and asking questions when they have them. It's not sort of this like taboo topic where kids feel like they have to like keep all their behavior secret. They don't want to go to their parents. And that's when I end up seeing them in my setting because they're acting out because they don't know how to manage their behaviors because no one ever talked to them about it.
Huh. So Are you aware of any research in like comparison studies between the United States and Germany of like people acting out in these inappropriate sexual behaviors? Like,
well, I do know in Germany there's what's called the Dunkelfeld Project. And so they have, it's super, super cool. They have like a completely anonymous like treatment for people who've committed sexual offenses. And the whole idea is on prevention. So they're trying to like get people involved in this before they ever commit a sexual offense. Whereas in the United States, everything is on the opposite end. Like all treatment available is after you've committed a sexual offense. You go to court, it's court ordered, it's mandated. And so I think that's a really cool part about Germany. They're trying to like prevent sexual offending. So I don't necessarily know any research that talks about like how often sexual offenses are committed or the difference in rates, but I do know that they have a very different approach to treating sexual offenses than we do here. And then I know with their sexual education programs, they saw a big decrease in like unplanned pregnancies and teen pregnancies just with their sexual education programs. And then teenagers are reporting practicing safe sex practices much more than they would here. So like using contraception, using condoms. Mm-hmm. I think part of when I've worked with parents, a lot of their fears around educating kids around sex is like, well, if we teach them, if we expose them to these things, they're going to start acting out or they're going to be sexual much earlier than they would have been. They're going to start being promiscuous. And the research does not support that. The research says when we expose kids to developmentally appropriate information, we're actually going to help them be healthier. They're going to like be more confident. They're going to practice safer sex practices. So I think that's a big part of it is people just have this fear of like, if we're talking to kids about sex, they're going to be like hypersexual, and that's just not true.
Yeah.
Do you think it's more important for schools to teach sexual health or parents?
I think both.
Both?
Definitely both. Because the schools, at least the schools here, I don't think the information that they're giving is adequate. And I think schools can run into some issues like let's take pornography, for example. The schools, I think, are going to run into issues when you have lots of different cultural and religious backgrounds and family values. And if you're educating kids about like porn literacy, I imagine you're going to have a lot of families that are really pissed about that. Oh, yeah. But I think that's super important. And so maybe that's what falls back on the parents is like, how am I going to educate my kids about porn? Because we know they're looking at it when they're 11, 12, 13. And you can't control everything that's happening at your house. So they go to a friend's house and their friend has a phone and they're showing them videos. Like you need to be talking to your kids about the content that's out there, how to use it safely and all of that. Like the schools probably aren't going to be doing that kind of work.
Yeah. Yeah. Instead of assuming that like, if you don't talk about it, they're never going to know it. Like,
yeah. Like, and that just creates an environment where then they don't feel comfortable talking to you about it. Cause it's like, well, my parents have never talked to me about porn or sex or masturbation. So it must be something that's wrong or bad or that I shouldn't be doing. So then I'm not going to go to them.
And then I could totally see it being like leading to very inappropriate behavior later on. It makes me think of like drinking, like when we were in college and going to Mankato, especially like a very heavy drinking college, and you go there and you can always tell the people whose parents never let them have a sip of alcohol because they're the ones that are like blackout drunk and all just totally like, oh my God, getting into trouble and then don't feel like they can go to their parents if they get a minor and stuff. And it's like, that just made me think of that. I don't know. If it's
that's exactly like the people that waited until college. They got after it way harder than the people that started in high school because they like did it with their friends, kind of like safe, like kind of discreetly, but they kind of knew their limits. But that's a good.
So like I know nothing about parenting strategies, but it kind of seems like you can't just assume that a kid is not going to get exposed to these things. Right. Like if you don't talk about it, it's not going to happen. The word you use was like developmentally appropriate, I think you said. Yeah. Like, I think that's the key word here. It's like people are like, oh, we don't want our kids learning about sex like when they're so young. And it's like, you're not going into the extent of detail that you would with somebody who is, you know, post-puberty, like sexually active and that. Like there is a little bit of a progress to that. Also, what was the name of the German thing?
Dunkelfeld project.
It's so German. Yeah. When you said it, I was like, that is so German.
Yeah, it's super cool.
Dunkelfeld.
Yeah.
I feel like we're never going to do that in the United States because we don't believe in disease prevention.
Well, I mean, we have opportunities. So like in an outpatient setting, I can see someone on an outpatient basis who hasn't necessarily committed an offense yet. But the difference is that they're having to pay for that service with insurance or out of pocket, whereas the court-ordered programs, those are paid for by Department of Corrections, Hennepin County, so people never have to worry about a single out-of-pocket expense. So we make it that much harder for people who are trying to be healthy and do the right thing by not acting out, but we make it so much harder for them to get services, and that's what isn't right.
Yeah.
When do you think is the right time to have the talk with your kid?
Not yet. Really.
I mean, I'm a dad. Not yet.
No, it's your kids.
Well,
not yet.
Not yet.
I think, Reed, though, I do think that there are so many books for parents that are just like, they can really help you with things like that. And it's just taught like the birds and the bees type stuff, or just teaching kids about body parts. That's part of sexual health education, just the different body parts and about consent and touch and body agency and all those things. You can start having conversations with your kids as soon as they can understand you.
Yeah,
I suppose. Because there's like a phase of child development where like kids that are toddlers become like obsessed with like genitalia for a period of time. And like it's not like they're taught this, you know, but like they... Like, obviously, I could see it being appropriate to have that discussion because kids are starting to, like, be curious about things.
That's funny because I was literally just talking about this with a coworker yesterday. Hopefully, she's, I think, going to listen to the podcast. So hopefully it's okay that I say this. But she has 3 boys and she was talking about how just, like, everything is sexual. They're, like, twerking. They're, like, humping the doorways. And she's just like, what the heck? Yeah. So it is, like, that's just part of kids growing up too. They're curious about their bodies. They start to discover that their genitals feel good when you touch them. And so you can have those conversations of like, I mean, I remember, well, maybe I shouldn't say that. Maybe not. But I've been around young kids before where they start to like experience some of that, where it's like little kids and they get an erection and they're like, oh, what's going on with my penis right now? Why is it hard? And so you can start having those conversations of like, this is what happens to the penis. There's a video that's called What Makes the Boner Grow? And there's a song that goes with it. It's really catchy, but like we can have these conversations with kids so they start to know what happens to their body. And I think it just creates a much more open dialogue and healthy conversations around it.
Yeah. So maybe it is time. Really.
Maybe it's time. Hey, miss, come here. I got to talk to you real quick.
Dad's got to talk to you about the birds and the bees.
But, and also I think like normalizing it. I've worked with some, young girls too. We're talking about boys right now, but girls too, where they start to notice that touch to their genitals feels good. I worked with a young girl who was kind of like thrusting up against couches, and mom was like, I'm really concerned. Is she masturbating? Like, what's going on? And the mom had such a healthy approach and response. She would go to her and be like, it does feel good when we touch ourselves in our private parts, right? But let's have some conversations around when that would be appropriate. We need to make sure that we're in private when we're doing that, when other people aren't there. And like, just having conversations, normalizing masturbation, normalizing self-touch, and then how do we do that safely, right?
Yeah. All right. To segue, can you put a definition on sexual health? Like let's define sexual health, and then I want to talk about like what is sex. You know, like the different types of sex, arousal, and orgasm, and things like that. But first, let's talk about like when somebody's trying to consider their sexual health. Like, how are we defining it?
Before I answer, I would like to hear from you guys. Like, what does sexual health mean to you? What do you think of when you think of sexual health?
Do you want to start, Luke? Because like I am.
No, you guys have to start because Luke's gonna have a different answer because he has more like.
Yeah, he's got the science behind it.
Yeah. So I want kind of like general. What do you think of when you think of sexual health?
Oh, this is tough. Right? I like tried to think of this one on my way here, and I was like, I don't know how to define it.
That's
you have to. You got to put it. You got to put a definition.
Joe, do you?
Is. Yeah, Joe, you got one.
Do you have like what?
Here,
what do
you got to grab the mic. You can sit on my lap.
Come sit on Daddy's lap.
Come sit on Daddy's lap and give a definition of sexual health.
Do you want my mic?
What makes the boner grow?
You guys, we should play that song too.
We might have to.
Yeah,
it's catchy.
That'll be like a little like
closing.
insert. Yeah,
the closing for today.
Definition of sex.
Here.
You should grab the mic though.
The definition.
Or like, what does sexual health mean to you? What do you think of when you think of sexual health?
Well, when I was younger, I was pretty good at it. So, working boners.
Okay.
This tough. This is like
so hard.
Well, like you were saying, it's a fucking taboo subject, so it's hard to talk about, especially
in our society.
With
it's kind of
your
like
brother.
awkward. Yeah, brother's right here.
And your dad's gonna listen to this too.
We're trying to normalize it, Joe.
So,
A working boner.
a working boner. If you have a partner, a healthy sexual relationship where you can talk about it, issues that go on, or no issues, or what you're into, and then maybe like, well, yeah, I guess, yeah, that's it. That's all I got.
That was a great answer, Joe. So we have like the sexual relationship or partnership. You have like whether or not you have a dysfunction, a working boner, not working boner. Can't remember. What else did you say?
I said
being able to have open communication around it.
Yeah, and when I was a kid, I was really good at it.
Okay.
You were good at sex?
Anything, Reed or Luke, that you guys would add?
My hand was really good at it.
Definitely, I think open communication is huge because if they don't know what you're kind of into, then it's just kind of like a routine kind of. You're like, all right, let's get this done. Let's do this. But like open communication is huge.
Yeah.
That I would say that's key. You got to really know like your love languages for people because like if they aren't physical touch, like I am. Mm-hmm. If you're more emotional, kind of knowing your partner a little bit better. So that goes to the communication. So that would be my only thing. I'm not well versed in this. Okay. But yeah, Joe, the open communication thing, you crushed it, man.
Yeah, I feel like if I'm going to put a definition on it, I think of like what, like physical health or mental health, like what kinds of things can go wrong and what kinds of things would we call like proper sexual function. So like I would think of a working boner. So the ability to achieve an erection, but also like the desire to have sex, the arousal with, sexual intercourse and the ability to achieve an orgasm without pain or, like anorgasmia, without having an orgasm at all. So like, ability to have sexual intercourse, want to have sexual intercourse, and have that sexual intercourse be pleasurable. And to be able to communicate with it, I'd say.
Nice.
That'd be my definition.
That was pretty good, guys. But I think part of the beginning was the point I wanted to make too of like how difficult it was initially to be like, oh shit, what is sexual health? Like what the fuck does that even mean? So it's super, super broad. I think for me, I like to think of it as like our ability to like embrace and enjoy our sexuality. And when I talk about it with people that I work with, I like to talk about it as the circles of sexuality when I'm talking about sexuality with clients. So the idea there's these 5 components or circles of sexuality. In the middle of those is our values. So First being sensuality. That's kind of what you guys were talking about in terms of our enjoyment during sex, our level of awareness of our body and our partner's bodies. So that can include things like body image. How do we feel about our own bodies? Sexual self-esteem. How comfortable and competent are we in terms of our sexual abilities? That's the sexual response cycle that Luke was talking about. Maybe our sexual fantasies fall under that category. The next component is intimacy. So that's kind of what Reed and Joe were talking about with relationships, kind of our need for closeness and intimacy with potential partners. And under that would fall trust, care, emotional vulnerability, self-disclosure, all those things with like open communication and how do we make our sexual relationship better. What we didn't talk about in your all's definitions would be sexual identity. That's that third piece. So how do we perceive ourselves as sexual beings? That can be our gender identity, our sexual orientation, our gender expression, different gender roles. All of those things have a huge impact on sexual health. And then we have sexual health and reproduction. So our attitudes toward and our behaviors toward sexual health and the consequences of sexual activity. So maybe our beliefs and values around contraception, whether or not we're trying to have a baby, our anatomy, history of STIs, all those pieces. Sexual dysfunction would fall under there. And then the last piece is sexualization. So that's how we use our sexuality. This is where people can end up seeing me, because this can be how we're meeting this need in really, really unhealthy ways. So that could include manipulation, force, rapes, but it can also be really healthy things like giving consent or trying to obtain consent, healthy communication in relationships, setting boundaries, flirting, courtship, all that kind of stuff. So that's kind of how I like to talk about it with people. And then just reminding people that sexual health is influenced by almost every aspect of our identity, our culture, our religion, our family upbringing, our values, societal expectations and norms. So all of that impacts sexual health.
Yeah. Will you list those 5 things again?
Sensuality, sexualization, sexual health and reproduction, sexual identity, and intimacy.
Okay. Yeah. And like that literally includes every aspect that you could think of.
Right.
Yeah. I like that. And I think that should really help drive home the point of like, there's so much of our day-to-day lives, our being, our physiological processes and functions that like relate to our sexual health. And it should only like help make sense of the fact that your sexual health contributes to your overall health. Like I know in a lot of these survey studies where you assess somebody who, you can see the survey scales. I'm not really familiar with like what surveys are used in the field, but like, do you have things like erectile dysfunction? There's tons of ED surveys and, how satisfied are you with your sex life? And you correlate these with somebody's mental health, like especially things like depression and anxiety. And like these things are very highly correlated and that is reproduced within the literature pretty well.
Yep.
And so, yeah, I appreciate the definition because now I think that helps people understand like, okay, this shit's important, right? So let's segue into, I guess, defining sex now. Let's talk about sex, like what types of sex, and we can talk about arousal, and orgasm.
Okay. When you say types of sex, like, are you
I guess I'm just thinking of like, okay, would we classify like masturbation or anal penetration, or like are there different like, what are we referring to when we say sex?
I think that's also going to depend on the person you're asking. For some people, sex might be just strictly penetrative. They might not consider kissing, masturbation, digital penetration, or like fingering as sex. But another person might say, yeah, that's totally sex. So I think it's going to depend on the person. There's also like, what was that?
Soaking.
Soaking.
There's also lots of like,
yeah.
I don't know what soaking is.
It's a new fad. All the kids are doing it.
That's
So
Utah.
it's like a Mormon
thing.
cultural thing where you can't have sex before marriage, but they'll like a guy will put his penis inside of a woman's vagina, and they'll just if there's no like
They can't thrust.
hip thrust,
Yeah.
it's not sex.
Interesting.
There was so you know how the Utah got a new hockey team?
Yeah.
Salt Lake
Yeah.
City,
Yep.
so there was there's a podcast, the Spit and Chicklets. I love hockey, so I'm always listening to like hockey podcasts. So Spit and Chicklets, these guys like do a podcast about hockey, and they put out a poll of like what should the new Utah hockey team be named, and like one of the top votes was like the Salt Lake City Soakers.
It's got a good ring
so
to it.
good, yeah.
They should have went with that.
Or the Stormin' Mormons. There were some good ones.
That's funny. So there's a lot of the like I think basic sexual behaviors that you named that everyone would think of, like vaginal penile penetration, anal penetration, oral sex, masturbation, digital penetration, and then we also have like lots of different like kink behaviors that I would say are still included in sex. So that's again a very like broad term.
Yeah. So it kind of encompasses like whatever
Whatever that means to you.
whatever you're doing to become aroused
Sure.
and put like hopefully achieve an orgasm, because I guess we'll talk about like, is it anorgasmia? Is that what the definition of like not
Like difficulty achieving orgasms?
Yeah, like not being able to achieve an orgasm. And I want to like, kind of lay the groundwork of like what is an orgasm, so that we can talk about a really like I can explain like the physiology behind like penetration, and like for a male, you're getting an erection is a process that involves.
Well, hold on. I just want to.
Yeah.
A person with a penis,
Person
because
with a
you
penis.
don't necessarily have to identify as a man or male to be able to like get an erection. So just
So
kind
a
of a more
penis.
inclusive. Anyone who has a penis,
Okay,
whether or not they identify as
so
male.
a penis, how to get a boner. The way you can kind of think about a penis is there's muscles within your penis, and there's these little like avenues within the muscle and between the muscle where you've got like your urethra and the arteries that run to the penis. And then outside of those muscles is like a casing called the tunica albuginea. And it's almost like this like saran wrap around the muscles and the artery. Right underneath that saran wrap are veins. So arteries deliver blood to the penis. Veins take the blood away. So when you get an erection, you have this huge flow of blood. That's what causes an erection. It's just blood there.
Yep.
That's what the erection is. And you have to dilate those blood vessels, the arteries that go to the penis. Now, when that blood accumulates, it presses up against that saran wrap, and those veins kind of get closed off. So they're stuck. So all the blood just stays in your penis. And that's
Why
what
are you saying penis so weird?
penis. Yeah, I don't know, because it's a sex
penis
term,
scene.
so like we're uncomfortable saying penis.
Penis.
Penis. So the blood goes to your penis, and then it presses against those veins, and the blood stays there. And I wanted to describe that because when we talk about erectile dysfunction, like there's a lot of reasons why the blood may not stay there, why that process may not happen, why you can't maintain an erection or get an erection, and so on. And you have this process so you've got all these nerves there. And this is true for the female as well. Like this is true for a vagina and a penis. Penis. I don't know. Like, honestly, that's how I said penis. So you have all these sensory receptors that are located, like very hyper dense in the clitoris and along the penis, also in the prostate, even some in the bladder that are really sensitive to touch. And that's what causes this arousal with stimulation. And then you eventually get this, what's called a positive feedback loop, where all these like neurons are firing and firing and firing. You get this accumulation of arousal, and then boom, ejaculation, orgasm. You have this like hyper subjectively like pleasurable state that will occur because
wouldn't that
this,
be like the release of the endorphins?
right? And that's what I was gonna say. Like because of this positive feedback that causes all these endorphin releases, and like there's still a lot that we don't really understand about orgasms, but it's one of the couple positive feedback loops we have in nature where like usually if something increases, then something else will cause it to decrease, or what's called a negative feedback loop. So like if I have cortisol increase, melatonin's going to decrease. Like there's these negative feedback loops throughout the day. Orgasm and sneezing, there's probably others, but I think of like, oh, and I guess when you have a child is another one too, but like those are what are called positive feedback loops, where you have this like buildup of these like sensory receptors, endorphins, and then all of a sudden, boom, they just like hit this threshold, and then you guys don't seem interested in science. Okay, that's I'm done with my tangent. All right, so that's what an orgasm is.
I just kind of like describe it to people as like muscle spasms and then a release of endorphins that make you feel good.
Yeah, that's way easier.
That's way easier.
Way easier than what I said. I did want to describe the penis so that when we talk about erectile dysfunction, because there's so many things with like exercise that I think we can relay back to that.
Okay.
But what else would you add to, I guess, like proper sexual function, arousal, orgasm?
Okay, so for arousal, I think it's important to distinguish between arousal and desire, because a lot of people get those two things confused. So arousal is our response to a sexual stimuli. So if we're being touched or we're being sexual, like Luke was talking about, we sort of have that arousal response, which we'll talk a little bit about. Desire is more like the drive to have sex, or like urges, fantasies to be sexual. A lot of people confuse those things. Those are different. So sexual arousal is the feeling of being turned on sexually, being horny. That's when you have all those physiological responses. So like what Luke was talking about, but there's also like heart rate increases, blood pressure increases, breathing increases. So there's all those other changes that are happening to your body. And then one thing I always want to talk about, especially the people that I work with, is that our bodies sometimes respond to sexual stimuli, even if we do not want to be sexual, if we're like not consenting. And this is like a biological response. And I always talk about it with people as like kind of an adaptive thing. So we'll take the case of a rape. Sometimes victims, if they're being assaulted, will experience vaginal lubrication. Sometimes they'll even experience an orgasm during a rape. And so they might go into therapy and they might say things like, did I invite this assault? Did I enjoy it? Like they might experience really intense shame around that. And that's a really like debilitating experience for a lot of people. And so for the people I work with too, it's really important to remind them that like, because that can lead to a lot of distortions for the person committing the offense. Is like, well, she, in the case of if it was a person with a vagina identifying as a woman, like she enjoyed it because she was wet or she had an orgasm. So I didn't do anything wrong. Whereas like our body is just responding in the way that it knows how, in a way that it's supposed to. And for me, I think of it as like an adaptive mechanism. So for a person with a vagina, if a vagina is being penetrated and it didn't lubricate, that would cause much more discomfort, pain, injury than if it did. Does that make sense? Yep. So like your body's trying to protect you in that, and your body responds to things even if you don't necessarily want it. Like that does not equate with consent. And so that is a really important message that I always want to give people, that like we got to be careful with that.
Yeah, that's interesting. I didn't realize that, you know, like it makes sense, but I didn't realize that occurred in like a rape situation.
People call that like a body betrayal. They feel betrayed by their body because it's responding in a way that's like counter to what they want. So not everyone, like by no means, but that is something that people have talked about. And that's something that I hear a lot in the people that I work with, is like, well, they showed some type of arousal response, so they must have wanted to be sexual. And that's absolutely not true.
Yeah. So the difference between like desire is the urge to like you want to have sex.
Yep.
And then arousal is like during the process of having sex, like how are you responding? So then let's talk about dysfunctions.
Do you want to talk about the sexual response cycle? Like
sure.
different. Okay. So a typical sexual response cycle has 4 stages. So there's excitement. There's that like buildup of where your body is getting ready to be sexual. That's where you might have the desire or urge to be sexual, plus the arousal, your body response. That's where those physiological changes start to happen. Then we have the plateau phase. That's where like all that arousal's ramping up. Your body's getting ready to have an orgasm possibly. That's that 3rd phase, which is orgasm, if a person can achieve an orgasm. And then the very end of the sexual response cycle is the resolution, and that happens whether or not you have an orgasm. That's just when your body kind of like returns to pre-arousal state. So that's what like a typical sexual response cycle looks like, and people can have dysfunction in different areas of those. So they can have desire dysfunctions where maybe they have low desire to be sexual. They're not wanting to be sexual. Maybe they have disorders with arousal. They're having difficulty becoming aroused or staying aroused, or they have difficulties with orgasm.
Yeah.
Are there things to like get over those, or are you kind of okay?
Yeah.
There are
Yeah,
ways
we can
to
talk
do
about that
okay,
too.
perfect.
Yeah.
Yeah, that's I think
think
when
that'd
we
be very
touch on like
important,
the treatment. I just had a thought before going into
Sexual health play in our overall health. Should we kind of go into that? Segue into that one?
Yeah, I mean, I think we've kind of like
Kind of
generally talked about it,
okay.
and then at the end when we recap like how it's so important for people, like this is normal, which I guess would be a decent segue of like what I think we should talk about next, unless you have anything to add of like.
I was going to talk about different like arousal patterns and some like distinctions between like male-bodied. Oh.
Yeah. Okay, so one thing that I know we talked about in medical school was a lot of people, and this is typically true for women coming in to talk about any sort of like sexual dysfunction because of the inability to achieve orgasm. And I remember talking about the differing like sensory receptor distribution in the human body, and especially within the vagina, and how like how achieving orgasm may require different types of stimulation. Like some people, like anal stimulation versus vaginal stimulation versus clitoral stimulation versus even like nipple stimulation, like will result in orgasm. And people are so different.
Yep.
And I remember talking about that. So can you touch on like different, how did we phrase that?
Like arousal patterns?
Yeah, that's what you said.
Sure.
Arousal patterns.
Okay.
Yeah.
So I have a question for you guys. Like when you think of male arousal, like what does that trajectory kind of look like?
What do you mean the trajectory?
Yeah.
Like, okay, maybe I just need to kind of tell you what I'm thinking. I think as a culture, as a society, especially in porn, there's like lots of pressure on men or like male-bodied people on like how quickly they need to get an erection. So there's sort of this like assumption that men should be able, male-bodied people should be able to achieve an erection on demand. They should be able to maintain it for fucking hours at a time. And they should be able to shoot ejaculate across the room, right? Like that is what we see in pornography. That's kind of this assumption. And so if you're any deviation from that, like what kinds of feelings and thoughts come up in you as a person if you're not able to meet that? So I think that like that's something to kind of consider, because I think we have really like unrealistic expectations of arousal for male-bodied and female-bodied people. But that's sort of like what people think of that trajectory looks like. And for female-bodied people, I think the conditions for arousal can be a little more complex. A lot of female-bodied people, not everyone, but a lot of people talk about their experience of where they need to have arousal before desire. So a lot of times when we think of sexual response, we think you have the urge to be sexual, then you experience desire, then you achieve orgasm. Whereas for a lot of female-bodied people, they need to experience that arousal first. So that might mean self-stimulation. Maybe they masturbate, maybe they watch pornography, maybe it's a partner who's initiating sex where they need some sort of sexual stimulus first before they then have the urge or desire to be sexual. So it's sort of a responsiveness instead of responding to a free-flowing stimulus, if that makes sense. So that can be a distinction where a lot of male-bodied people talk about that desire coming first.
Yeah.
Does that make sense?
Totally. Because that's a like area of some of like the female performance enhancing medications that are FDA approved. I say performance enhancing. I don't know how else to put it, but it's like the Viagra for women is
the blue chews. Yeah.
Like a lot of them target that like desire prior to arousal. Like how can you increase the desire prior to arousal? Because like that can totally be dysregulated in people, or like not even dysregulated, but you just may not be or achieve desire until you're aroused.
Yeah, and that's okay.
Yeah.
But I think that's important for people to be aware of too, because sometimes that can cause resentments in a relationship where one partner feels like, why do I always have to be the one to initiate sex? Or maybe they're thinking my partner doesn't want to be sexual with me because they're not initiating, but maybe that just means that they have a responsive desire versus a spontaneous desire. And that's just part of kind of how sexuality or how arousal works for them. Then I had another thought. Maybe it was about orgasm too, because you were talking about, I can't remember what the time was, but I was reading something about how if there's like a man and a woman, a man thinks that it should only take a woman like 4 minutes of sexual stimulation to achieve orgasm, when the actual number is like much higher than that. So people with vaginas maybe just need a lot more time with arousal to experience an orgasm when compared to a person with a penis.
Or different types.
Different type. Yeah.
And I think that's like, I remember that from the early on med school training is like, you may not have an issue achieving orgasm. You just may not know the type of stimulation required to induce orgasm, because it is not, always just penetration for people.
For a lot of people, it's not.
Right.
It's like clitoral stimulation. Sometimes people with vaginas can only achieve an orgasm on their own and not with a partner.
Yeah.
How do you know these things? Like,
that's where communication is so important. Like, you just have to talk about like, this is what works for me. Well, then I think like encouraging some kind of self-exploration for that person, maybe masturbating by themselves to kind of like find what areas feel good for them, what kind of contact feels good, so then they can communicate it to a partner. Sometimes, again, like culturally, societally, we have given really negative messages to female-bodied people about masturbation. They're dirty if they masturbate. You know what I mean? Like, it's not as socially accepted as it is for male-bodied people. And so I think it can, for some people, come with a lot of shame. And so it's like not a behavior that they feel comfortable engaging in or feel comfortable talking about. So that can be a thing too that maybe they address in therapy for like, what does it mean about me? And why do I have that messaging? And how do I work around it?
So if you were to have someone, let's say like you were working in like a sex therapy type setting, and someone came in and had an issue with arousal, would that be your first approach of like, okay, you might not actually have an issue with arousal. Like, here's some self-exploration, and then we'll schedule a follow. Well, I guess I'm thinking more of like physician. Schedule a follow. Like you'll continue to meet with that person throughout. But that's kind of the approach that we were led to in our training, was like, you would assume that it is not actually like the anorgasmia diagnosis. It's, oh, this individual may not have or may not know their own requirements for stimulation. Like, go figure that out, however that might be. That just made me think of, there's like a Joe Rogan skit where it was one of his like stand-ups where he talks about masturbation. He's like, it's super weird because everyone masturbates, but if you ever get caught masturbating, that is going to be the most embarrassing thing of your life. Yeah. You know everyone's doing it, but if you ever get caught doing it, that will live with you forever.
Except maybe if you're somebody who works with me and you want to be caught doing those things. That can be some of the thrill.
All right, so to segue into like dysfunction, you know, I know that there's a huge percentage of people that suffer from sexual dysfunction, whether it be, you know, low desire, low arousal, inability to achieve orgasm, inability to attain an erection, inability to lubricate. And these issues are so prevalent, but just not talked about. Like ED, it's like
50% of people over 50.
Yeah, okay. I was just going to say the statistic is like 50 over 50, 60 over 60, and 70 over 70 or so. Like there's this trend of like, it's so prevalent. And I don't know the statistics for like females and things, but like these issues exist and people are so uncomfortable talking about it.
Well, and that is just like erectile dysfunction. Whereas like if we just talk about occurrences of difficulty achieving orgasm or difficulty achieving erection or maintaining an erection, that happens way more frequently. You know what I mean? Like under the level of disorder. Does that make sense?
Yep.
How much of ED is like mental?
How much of erectile dysfunction is mental? We're going to talk about that.
Yeah, because and I think we could go right into that of like erectile dysfunction. You can classify erectile dysfunction as I can't remember the acronym of like vascular, endocrine, neuro, or like psychological or trauma.
Yep.
Vent, I think, is what we learned of like there's so many things that can contribute to you not being able to get an erection. And yeah, let's talk a little bit about that. Like,
okay. So for what I have learned about erectile dysfunction, that's definitely the most common sexual disorder. There's usually a physiological basis for that. So a lot of medications can cause erectile dysfunction, SSRIs, so like medications to treat depression and anxiety, high blood pressure medications, cholesterol medications, like anything with the heart. I also was in a training about like counseling couples with sexual health issues, and the trainer was talking about how she consulted with a cardiologist, and the cardiologist said that if erectile dysfunction comes like completely out of nowhere, it's a very new thing for that person, it also might indicate cardiac distress and that some type of cardiac incident is about to happen. I don't know if that's like a heart attack or something like that, but that was really interesting to me.
Yeah, there's like that group of literature of like cardiovascular disease. You look at the risk factors associated, and the only reason I'm familiar with this is because of like low physical activity, smoking, and all those things. But erectile dysfunction is one of like the earliest signs of cardiovascular disease for somebody. Like you can predict if somebody's going to have some sort of cardiovascular event, heart attack, you know, just hypertension, atherosclerosis. I can never say it.
That's a tough one.
You can predict that person either has or will have that based on erectile dysfunction, which is just kind of crazy.
Yeah. So talking about the psychological aspect of that. So I'm not going to like make you guys say if this is an experience you've ever had, but we'll just say hypothetically, if you were to have difficulty achieving an erection or difficulty maintaining, what feelings would come up with you? For you?
Yeah, I'd be pretty bummed out.
Depression.
Then it's like, my thing's
out.
not working. Like,
yeah.
Is there something wrong with me?
So like insecurity, anxiety.
Am I not like in like with your partner? Is something going on? Like, is there distance or something?
Yeah,
like,
so I was going to ask about that too. Of like, would you be thinking about your partner's experience, and would you have concerns around that?
Yeah, like what they're feeling. Like, oh, he's not getting hard. Like, is it something I'm doing? Is it something about me? Like,
yep, like
that kind of would draw.
You're kind of like projecting or wondering what they're thinking about the experience.
Yep.
Right. So then, like, what's the worst thing your partner could do in that situation?
Ooh. Hypothetical.
I think that it's their fault.
No. Get like upset with your non-working boner.
Yeah.
Yeah. I'd say upset or like blame themselves, and then you kind of are like lost. You're like, what? Like,
yeah, blame either
that's
one.
not it at all. But then you upset
well, like,
and then blame themselves.
If you don't have a working boner, you're already self-conscious about it.
Yeah.
And then they're like, yo, what the fuck is wrong with you?
Yeah.
And you're like, I don't fucking know.
See, and then that's like anything psychological like that causes a snowballing effect of like once it happens, it's more likely to happen again.
That's
I think
exactly
of like golf.
it.
Like if you're like so focused on one thing, like you're putting, like, oh, I know I'm going to be like super tense with this putt. And then it's like every time that you like overthink it, it's going to happen. You're going to tense up. You're going to miss the putt.
happened to me when we went golfing. I was like, oh, I haven't chunked it yet off the tee. I haven't chunked it, guys. I'm not going to say it.
And then that's all you're thinking about. Yeah.
Yep.
On that par 3.
And that's exactly what happens with erectile dysfunction and like the psychological aspect of it. Like people experience it. They feel shame, embarrassment, insecurities. They're worried about their partner. Like, does my partner think I'm not attracted to them? Do they think, you know what I mean? Like, is something going on there? That just creates this huge anxiety cycle. So then the next time they're having sex, they're anticipating, I'm probably not going to be able to get an erection. They're in their head so much that like that is then contributing to the problem. So when we're trying to like assess erectile dysfunction, it's like, okay, we need to try and figure out, is there a physiological reason for this, or is this mostly psychological? And that's going to determine the treatment. So I would say for erectile dysfunction, with I would probably encourage that person to like talk to a doctor at first. Like I can ask some of those questions. I can be like, are you on an SSRI? Do you have like cardiac issues? But I'm definitely not an expert in that. I would want them to probably get evaluated by a physician first so that we can at least rule out those medical reasons.
Mm-hmm.
Yeah, I know one easy way to like approach that, like, is it psychological versus physiological before doing a bunch of tests is like, do you get morning wood or do you get an erection when you masturbate? Because if you get an erection when you masturbate or you get morning wood, a boner in the morning, then it's psychological. There's no physiological process. So I know those two questions are like, helps you figure out, is it psychological or not?
Sure.
And then like, as far as like diagnostics in like the medical field, if someone comes in and you think, okay, maybe it is vascular. Yeah, you'd look at their medications and the big ones, SSRIs. I don't really know all the medications that induce erectile dysfunction. I imagine there's a lot.
A lot, yeah. I think most medications have sexual side effects.
Yeah, I know that, like, but you can do these like ultrasounds to look for vascular induced erectile dysfunction, where you'll inject this medication that will dilate the arteries, increase blood flow, basically just like give you a boner whether you have erectile dysfunction or not. And then you use an ultrasound and you measure how much blood flow is coming in and how much blood flow is coming out. Because what happens with age, especially, like, you know how we've talked all about muscle in this podcast of like when you age, you lose muscle. That happens within your penis as well. And so those muscles that have to press up against that saran wrap, the tunica albuginea, with the veins to constrict them to keep the blood flow in your penis. When you lose muscle, you don't have the ability to like press up against there. So you get vascular leak or venous leak, and the blood will actually leak out of your dick. And so when people age, that's one of the reasons, along with if you have poor vascular function, you can't dilate the blood vessels to deliver blood to your penis. And so we've talked about like with exercise, how you can improve the ability to direct blood flow. That's true to your penis as well. It's not just to, your muscle organs and all that. So you have a better ability to increase blood flow to your penis. And then you wouldn't really influence your penis with exercise in terms of muscle. But there is actually something true. Was that about to be your question?
Say, do you know any penis exercises?
So there is like there is a theory of like, and again, these are all just survey analyses of you look at people who use their penises more frequently, you're using those muscles. Makes sense just like any other muscle. And so like, if you don't use it, you lose it is actually kind of true in this instance too. But I bring up the like structure of the penis again, just to like highlight the importance of exercise for vascular function. But with that ultrasound, so you can diagnose it by seeing how much blood is leaking out. And that's why some people will use like a band around the base of their penis to keep that pressure, to keep the veins from being able to like leak that blood
like
out.
A cock ring?
Yeah.
Okay.
Like, and that's like, if you can get something on the base of your penis that will constrict, and the blood will still go in because those arteries are in the middle there, but the veins are on the outside, so you can close them off so the blood will get stuck. So that is like a technique people will use. But yeah, that was my tangent about like diagnosing.
I have heard that too. Like I was listening, I think it was on the radio. It might have been K-Fan, but a nurse at a nursing home said like older people have sex a lot, and if they don't, it's kind of like use it or lose it. Like they like can't get erections anymore. So like that was like spot on with what I was going to talk about too. So
sexual functioning does decrease with age too. Like that's just part of aging.
Yeah. Do we know, like, do we lose arousal? Do we lose like the ability to achieve orgasm? Like I understand the like anatomy of it, like postmenopausal women, estrogen influences the ability to get wet. What is the term for that?
Vaginal lubrication.
Yeah, that was what I was trying to think of. And so when you don't have vaginal lubrication, sex can be more painful. And same thing with men. Like as you get older, you lose the ability of erection. Like I understand that makes sense, but is there a change that you're aware of like desire and arousal during sex and ability to achieve orgasm?
I think definitely arousal. So like as people with penises age, it becomes, like you said, more difficult to achieve an erection. Their erections become less like hard. And then it can be more difficult to ejaculate. And then for people with vaginas and postmenopausal, vaginal dryness is a thing. I think orgasms can be less intense. Like the muscle spasms are just not as intense for people.
But as far as like the psychological influence, like, I suppose if you think about it in terms of like, if you're not able to achieve an orgasm like you were before, you may have lower desire and that does, I guess, make sense. But do we know of any like process of aging that changes just sexual desire in general?
I don't know. I wonder though, like, again, culturally, societally, all the messages that we have around aging people and sex, how there's kind of a stigma, or we think it's like gross when older people have sex. And so I wonder if that also contributes to people's desire too, of like the messages that they receive around that. And
yeah,
I would imagine that has an impact.
So let's say client comes back to you after talking with their physician and it's been determined that they have psychological erectile dysfunction. Like, what's your approach there?
Again, I think it would kind of depend. I would want to try and figure out more of the source of the problem. So for some people, it's like, maybe we just need to shift the focus and the mindset and change our attitudes towards sex to where it becomes less about performance and more about pleasure. So sometimes if there's like erectile dysfunction within a coupleship, people they did get like sex homework, they have sex dates, but the homework is actually to not have intercourse and to not have an orgasm. It's more about just like sexual play, exploring each other's bodies, sensory experiences like massages and things like that. So we're taking the pressure off the person to achieve orgasm. It's more like, let's go back to the very beginning. Let's make this goal about having fun with each other, enjoying each other sexually, and not about having an orgasm. And sometimes that really helps, just kind of taking that pressure off to where then they have, it's usually like a 6-week process to like erotic recovery, to where they're practicing those behaviors, to where that piece can be helpful. Sometimes for people, part of the issue is like their own anxiety around it and like predicting that that's going to happen. So maybe there's some like mindfulness techniques that they can be doing, like something to manage the anxiety so that it doesn't continue happening. If part of the cause is a partner's negative reaction, maybe there can be some couples work where we're talking about like, how can we respond differently if this happens? And let's take away some of the shaming messages and work through that. So I think it kind of depends, again, on like the psychological reason or cause, like what is it stemming from?
Yeah. So do you treat it similarly to you would any like anxiety inducing issue in someone's life? Like, let's just explore this further and let's come up with techniques that work for you. Mm-hmm. Yeah, that makes sense. The, I guess for like the medical treatment side of things, I don't know. Well, I shouldn't say that. I know that you actually, like physicians will prescribe a low dose of whether it be like Cialis or Viagra, something that will assist in the erection for like confidence reasons. Mm-hmm. So that that person could, I believe that's an approach, like a low enough dose of like, okay, let's get you more confidence so that you don't get into that like spiraling effect that would happen. But I don't know like other like psychological treatments that you could use from like a medical perspective. I'm saying like drug, like you wouldn't prescribe an SSRI, you wouldn't treat the anxiety.
Right.
Maybe you would, I don't know. But like, if it's anxiety associated, like it seems like the most appropriate approach would be meet with a therapist, not with a physician.
Yeah. The only other thing I can think of is like, if it is like a cardiovascular, like metabolic issue that's causing it, then maybe like exercise or some sort of protocols around that could be really helpful too. Cause like people with obesity or like diabetes and other things like that can have erectile dysfunction. So if it's managing those illnesses or diseases through exercise or through other means, then maybe has a positive impact on erectile functioning.
Yeah, but I think that relates more to like the physiological erectile dysfunction of like vascular function. Yeah. It's kind of funny, like, do you know the story of Viagra, like how it got approved in that? We were talking about this in like our pulmonary unit of med school where we were learning about pulmonary function. So you can get pulmonary hypertension. Joe, I know your cousin like works in an area with that.
Carl.
But shout out to Carl. Yeah, shout out Carl. One of the early medications that was tested for pulmonary hypertension was this vasodilatory drug, which was Viagra. And they tested this drug in people to see if it reduced pulmonary blood pressure. And they found when they were looking at the data, there was no significant change, but they observed that like not as many people returned the medication in the actual treatment group versus the placebo group. And so then they like did like a survey analysis and stuff. They ended up figuring out people were getting erections in this group and wanted to keep the medication. And it was like improving erectile dysfunction. So that's what led to it getting approved. And
imagine taking that and all of a sudden you're walking to work or at work and you're like, what the?
I don't know, I'm taking this new medication. I'm in a study. But yeah, that's good. So, and Viagra is basically, it just helps open up the blood vessel that will deliver blood to the penis. And so you get this increase in blood flow. And Cialis is another one that has the same mechanism, but will actually act for longer. So like you can take a Cialis pill and it will have the same effect as Viagra, but it will sustain for like 24 or think even like 48 hours with one medication versus Viagra is like you take before you have sex and it will like activate this process in like 45 minutes, but doesn't last. Well, if it lasts longer than 4 hours, make sure you go talk to your doctor. But those are the medications I'm aware of. I know there's a newer like FDA approved ED med, but I don't know enough to talk about it. But yeah, other ED, so the physiological, psychological cause, and then obviously like, what is that disease? I was talking to you about this Peniers, where it's like trauma-induced erection of like you get the scar tissue and it, like the penis will bend
90 degree.
Mm-hmm.
That's also like pretty prevalent. I know. I don't know the treatment of that, but yeah.
You said 10% of men have it.
Yeah, it's like 10% of men have this problem of like trauma-induced. Like if you like break your penis, you can fracture your penis pretty much, and you get the scar tissue build up if that happens when you have an erection, and then you'll continue to have an erection, but the scar tissue will be on like one side of the penis and will cause the penis to bend. And I know there are interventions to help with this. I just don't know exactly what they are. But yeah, side tangent. You guys got to bring me back.
No, I was interested. We were talking about it earlier. I was like, oh, maybe Toni had something to say about that one. But that I've never heard of that one before.
Yeah, Peniers, I think.
Yeah, 10%. That's crazy. Yeah.
Mm-hmm.
All right, other ED thoughts?
No.
How would you say, what would be like the best approach to your partner if they don't, I mean, in our society, we don't really like to talk about like sexual stuff. Like, what's a good way to approach your significant other to like open up about it and have them?
For the person who's experiencing erectile dysfunction or the partner?
I'm just saying like in general to like improve your sexual health. Like what's a good way to approach your partner to just be more open about it? Because like we're so reserved. I feel like in our society, we're so reserved. It's awkward to talk about.
Yeah.
Like, how would you?
I think the best approach is definitely just being direct. And you can even, I always say, like, if it's something that makes you feel insecure or embarrassed, just name that. And going to your partner and being like, look, I want to talk about what happened. I feel really fucking embarrassed about it. I'm nervous to have this conversation. It's awkward. And just like naming that can kind of take some of the pressure off. And just saying like, I want to talk through this with you. And for the partner of the person who's experiencing erectile dysfunction, I think it's really important just to like normalize that like, hey, this thing happens, and it can be really helpful for your partner to just like remind them that like, I still enjoy being sexual with you, even if you don't have an orgasm or you can't maintain an erection. Like there are other things that we do. Like X, Y, and Z in our sexual relationship, and we can do more of that. Just kind of that reassurance that like, it's okay. There are other aspects of our sexual relationship that are enjoyable, so that it's not like a shaming or negative reaction to that. But in terms of approaching it, I think just be direct.
Yeah. What if your partner has like your X, Y, and Z is completely different from your partner's X, Y, and Z? You're like, oh, I want to do these things in the bedroom. And then your partner's like, I don't want to do any of those things. Like, how do you...
That can be really hard.
Yeah. Like... Is there any way around it, or you just kind of compromise? You just kind of...
I think that would be an area where I would encourage people to like do some couples counseling, because it's really helpful to have like a third party kind of like directing some of those conversations and knowing what questions to ask. Because if you're like a lot of people, you're like avoiding that, or you might be too embarrassed to say, these are what my sexual fantasies are. This is what I desire in our relationship. And sometimes people feel pressured to like engage in that behavior, even if they don't want to, or, you know what I mean? Like there's just a lot of dynamics that go into that. So I think if you're discussing that with a therapist, it's probably the best approach. Because that can be really, really hard.
Yeah, absolutely. That's perfect. And where would you like to segue? Those are just questions I had just from going all that stuff.
What additional... We'll come to you, Joe. Don't worry. What other... So what are some other common... like erectile dysfunction, I imagine, is the most common issue for males. Now, what's the most common... People with penis. What's the most common for females, people with vaginas?
Most common for people with vaginas is like a low arousal disorder. So some ones we didn't touch on for people with penises would be premature ejaculation. One we didn't touch on. And then both people with penis and a vagina can also experience like the decreased sex drive or low sexual arousal. So hyposexual arousal disorder for people with female bodies is the most common.
Should we stick with the penis for a bit and talk about those other ones?
Premature
and then
ejaculation?
Go?
Yeah. Sure. So premature ejaculation, just like ejaculating sooner than a person wants to or sooner than their partner wants to. What do you guys think is like the actual average amount of time for penetration?
1 minute, 30 seconds.
I would say 10 minutes.
10 minutes?
I'm pretty sure 3 minutes is like...
I've seen anywhere from like 3 to 13, 4 to 7 kind of seems to be like that middle ground. So yeah, I think for a lot of people that like think they have premature ejaculation, this is a lot of times just coming out of like really poor sexual education. They're like, I have premature ejaculation because I can only have intercourse for 10 minutes. And it's like, well, that actually is, on par with most people. So for that, it's mostly just like educating people about sex.
Well, and then the porn videos, they're all taken. It's not real.
Right. Porn is completely unrealistic expectations of sex.
They, get back at it, but the cut, you can't see the cut. They just change positions, and they're just doing it for an hour and 45 minutes.
Yep.
It's not
just all upset over here.
Yeah, so that's a huge one for people. I think porn is a contributor to that, where they just don't realize. They think that there's something wrong with them because they can't have that typical like penis trajectory of where you can get an erection on demand, maintain it for hours at a time, which is just not realistic. This one typically doesn't have any physiological causes. It's almost always psychological. And the medications that cause erectile dysfunction can be used to treat premature ejaculation. So they can use SSRIs to delay ejaculation for people.
What's the time frame for somebody? So like, would it be like a minute and be like, okay, I do have it. Like,
I've seen
lasting
like
a minute.
1 to 3 minutes.
1 to 3? Okay.
Yeah.
So if you hit 3:01, you're like, good.
And it also kind of depends on like, sometimes people maybe like 3 minutes is the time it takes to ejaculate, but maybe that isn't a problem for them or their partner. So it's like, who cares? So
I had a friend in college. He said anytime he would about to, he'd think about dribbling basketballs. Is there like a mental thing to it?
So yes, I have definitely heard that where anxiety is a huge piece of premature ejaculation too. And I've heard of people that say like, oh, think of hairy balls or like think of something that's not at all arousing. That's actually the opposite of what we want you to do if you have premature ejaculation. So you're not supposed to distract yourself. We actually want you to be a lot more mindful of your body responses. So like focus on your sensations because so some of the techniques that you can use to prevent premature, actually, okay, before I do that, let me ask you guys, how did you learn about ejaculation?
Like, how did I learn about ejaculation?
Yeah, like what was your first experience with ejaculation? How did you learn about it?
This is like 7th grade.
Yeah.
Like, first time I experienced ejaculation, I don't know, when I was a kid, touching myself.
Yeah. Randomly happened. And then like kind of through your friends, they talked about it in like 7th grade. That's kind of, I feel like that's the peak time.
I guess
for
I
boys.
don't really,
So, 7th grade.
Like, what happened?
For a lot of people, their first discovery is masturbation. So when you're masturbating in 7th grade or when you're, 12 years old and you first discover it, what does that process look like for you? Is it something where you're like slow and you're trying to enjoy yourself and you're comfortable and you're like, I need to fucking get this over with quick so I don't get caught. Like my mom better not walk into the room. Like you're trying to be fucking quick about it so you don't get caught.
Oh, so psychologically, I see where you're going.
Right. Like for a lot of people, premature ejaculation is kind of habit. So when you're masturbating quickly, you're trying to achieve ejaculation as quick as you can, it's creating this neural network in your brain that like ejaculation should come quick. Mm-hmm. And so for a lot of people with premature ejaculation, it is like relearning how to ejaculate. So back to kind of my original point of like why we don't want you to think of the hairy balls when you're dribbling a basketball. We want you to be really focused on your body sensations, because what you can do is like the stop-start method. So when you're being sexual or if you're masturbating alone, you want to be aware of like right before you're about to ejaculate. Then you stop, pull back, restart again. When you're almost there, pull back, restart again. So it's something that people should like practice over and over again to kind of relearn
it's
that.
Like exercise into failure kind
of
thing.
Right. So you can do it alone. You can do it with a partner.
Multiple sets.
Sets. So like your body will, like you can do this on your own. You don't have to get medications, just like practicing to build that. Oh, look at that.
Yeah.
Exercise.
I didn't even think about the fact that like you would treat that with an ED inducing medication, like the course of treatment there. So that's
wow. Yeah, don't think about basketballs.
No.
Okay, that guy was totally wrong.
You want to be more in your body and more present there instead of like distracting.
Just take breaks.
Because that allows you to like take more control over your arousal.
So is that another psychological issue then, like ED, where when it happens, it's the snowballing, like gets worse and worse and worse?
Or kind of more just like habit, right? Like the neural pathways in our brain just kind of associate it with that. It's just sort of, that's how it's always been.
Yeah.
Can be that for people.
Other penis probs?
Penis.
Penis.
Do we want to talk about decreased sexual desire in people with penises?
I think we can group that. Like
all together?
Desire. Unless, well, that's up to you. If you've got
like low sex drive or decreased sexual desire. Well, for like etiology for men can be sexual dysfunction. So if they're experiencing erectile dysfunction, sometimes that just like leads to avoidance of sex altogether. They just like stop wanting to have sex because they're ashamed, they're embarrassed, they think it's going to happen again. So then they just stop wanting to do it. Feeling criticized by a partner can be another one. Low testosterone can be another one. And I don't know if you want to say more about that, but causing a low sex drive. And does low testosterone just comes with aging too? So like as men age, as people with penises age and their testosterone decreases, so then therefore their like interest in sex can decrease.
Yeah, that's exactly what happens. You do see a decline in testosterone with age. You also see this in women with oral contraceptive use. This is a growing area of research of like when you're increasing estrogen, you increase what's called sex hormone binding globulin that binds free testosterone, and women need testosterone too, and that contributes to desire. And so you see the same process. But yeah, that's exactly what happens. Okay. When you age, it declines.
Yeah. And then other etiology for low sex drive in men, just like fatigue, just being really tired, stress, excessive use of porn is an interesting one too.
I've heard that.
Yeah. If you're just like whacking it all the time to porn and you're not really interested in having sex in real life, that can happen too.
Yeah, if it like can change your like perception of like what you desire.
Yep.
People desiring different types of intercourse and all that.
Yeah, because we've already talked about like porn is not realistic at all.
Yeah.
So the like novel and spontaneous experiences that you're seeing in porn typically doesn't fit with people's sex in real life. Mm-hmm. So then they lose arousal too. Yeah.
So should you just masturbate to nothing?
You can use porn. I just think you need to be like critical about the porn you're watching. Like,
sorry.
Do you want the mic?
Sorry, I got some stuff.
So, I don't know about you guys, but I'm sure you've watched some porn.
Never heard of her.
Oh,
that was wild.
After the ejaculation, don't you feel a little ashamed?
turn the shit off.
You're like, all right, oh man, I can't believe I just did that. Anybody?
There's a funny skit. I love comedians, and Tom Segura talks about not that specifically, but like the shame after ejaculation. Like, oh, this is too inappropriate.
Poor girl. Oh, she's trying to do
Yeah. Never mind.
that. I might take that out.
So for female-bodied people with low sex drive or hypoactive sexual desire, causes are typically hormone, like disruptions with hormones, anxiety, stress. Body image issues can be a really big one there because, like, for people with a vagina, it can be, like, I'm going to say virtually impossible to have an orgasm if you're not relaxed. So if you're not able to, like, be present in your body, it's going to be really difficult. Sexual abuse can also be one where they're just not interested in sex because of the trauma of being abused. Spectatoring is one really interesting thing that I've learned about in my training, where, like, it's kind of where you, like, leave your body during sex. It's kind of like you're watching yourself having sex, which again is really hard to be present in your body, difficult to achieve an orgasm. But there was one study that I learned about where they did fMRI studies comparing the brains of women with hypoactive sexual desire to women without. And there was increased activity in, I'll probably say this wrong, but the medial frontal gyrus and the interior frontal gyrus, which is associated with heightened attention to self and others' mental states, and then suppression of emotional responses. So that's kind of that, like, spectatoring piece. So there's this thought that maybe for female-bodied people with hypoactive sexual desire, those regions of the brain that are responsible for self-monitoring are lowering their ability to be responsive to sexual stimuli. So I thought that was really interesting.
One of Reed's Reddit.
Luke's like,
I don't know about
that.
No. I'm trying to piece together what you just said. Like,
So, like, the parts of the brain that are responsible for, like, attention to ourselves and attention to other people are, like, heightened in female-bodied people with hypoarousal. So that spectatoring, where they're kind of, like, watching themselves being sexual during sex, could be what is contributing to, like...
Define watching. Like, does this mean, like, filming, or you, like,
No,
feel outer
like,
body?
You
outer
feel
body
out of
experience.
body.
Oh,
You're
okay.
like,
I was like...
You're, like, watching yourself.
Yeah, I get you now. Okay.
So, Joe, I think this is a section, like Riley said, to cut out when, like, I'm having to ask questions for you to specify, because the listeners might have totally understood you. But what you just said is, like, people who have an increased capacity to, like, perceive their own or someone else's emotions are the population who is hypoaroused?
Yes.
That seems counterintuitive to me.
In brains of women. And so it's also the parts of the brain for suppressing emotional responses. So I think the idea there is they're basically not present.
Gotcha.
They're not present in the sexual experience. They're in their head. They're thinking about their body's experience. They're thinking about their partner's experience instead of, like, in the arousal state.
Yep.
Does that make sense?
Yep, it does.
Okay. Then the only other dysfunctions I had on my agenda were sexual pain disorders. So this is typically, I don't know if, like, you have know of anything different, Luke, but for me, when I think of pain disorders, it's usually people with vaginas. I don't know of any pain disorders of people with penises, but it's typically, like, with penetration.
Yeah, the only other thing I can think of is, like, the penile fracture.
Yeah, okay.
But yeah, no.
So for sexual pain disorders and penetration disorders, it's essentially, like, involuntary contraction of pelvic floor muscles. So any type of penetration is extremely painful for the person with a vagina. Sometimes it's to the point where, like, even inserting a Q-tip is extremely painful. So there's a difference between, like, long-term, the person's experienced that with their first penetration, which could be, like, inserting a tampon, or there's acquired. So they've previously, like, had a time where they've been able to enjoy penetration, or it hasn't been painful, and then it comes about. So this can have a lot of medical causes, like frequent UTIs infections, fibroids. I don't know if there's like maybe cancers or something like that that could impact it. Also trauma, sexual trauma can be a big one for that. And then one thought that I had is just that like how difficult that can be to treat medically, because I imagine that to diagnose, you have to do some sort of exam, which would be like inserting a speculum, which would be extremely painful. So like, how do you even...
Yeah, if there's some sort of like cyst, or whether it be a benign or malignant tumor or whatever, you can do like ultrasound scans of like the uterus, the cervix, vagina. But yeah, I don't know. I mean, you got to go in there with the speculum, and those things dilate quite a bit. That I don't know.
Well, there are like some treatments for people with sexual pain disorders. I mean, one easy, obvious one, well, I guess I shouldn't say like easy, because that is a big factor for people, but like non-penetrative sex. But sometimes people want to have penetrative sex, so that isn't, I guess when I say easy, that probably wasn't the right word. But pelvic floor therapy, physical therapy, I don't really know what that entails. I just know that's something that people get referred for. And then...
what about muscle relaxants?
Yeah, there can be like lidocaine type stuff, muscle relaxers for that. And then they do have like dilators that look like dildos. There's all kinds of different sizes so that people can start to like practice.
Kind of like gauges in your ears.
Yeah. So they like get the vagina used to increasing amounts of penetration.
Yeah. The like pelvic floor side of things, that is like common area for people after they deliver a baby. So your pelvic floor is, you can think of it as like this basket that holds everything in your pelvis, like nice and structured. And so after you deliver a baby, you could think of like those muscles are stretched out quite a bit. And now you don't have proper structure of your vagina, of your rectum, of everything in your pelvis, like your bladder. This is why after pregnancy, people might have like leakage of urine from sneezing or just jumping and things like that. But strengthening the pelvic floor muscles will help improve or get that back to baseline. So yeah, I know that is like physical therapy technique used for people with issues with sexual.
I used to train females that had kids. They're like middle age, and they would do like jumping jacks, any jumping activities, like pee would come out. I didn't know that when I was a trainer, and they're like, I can't really do this. So like doing pelvic floor exercises could
and like Kegels.
Yeah.
So that would actually help.
Pelvic floor
I should have put that in their workout.
Yeah, Kegels.
I was like, I'm not gonna do any more jumping with it.
Bring back Kegels.
Here's some Kegel exercises. That's a fun word to say.
I gotta see if I had anything else.
I can jump into my Reddit reads. I just got one good one, and I think this would be a good segue. But I feel no sexual desire for my partner, and it makes me feel empty inside. I feel like I'm failing, and it's causing arguments. And
I shouldn't laugh. I just looked at Luke's face.
Oh, looked at Luke's face.
It
just kind of segue from like.
Okay, repeat the.
I feel no sexual desire for my partner, and it makes me feel empty inside. I feel like I'm failing, and it's causing arguments. And she kind of goes to say, this is a female who wrote this on Reddit, and she said, I cannot bring myself to sleep with him. I enjoy the physical sensation of sexual contact, but I have no desire to initiate it. Do you have any like words of advice for this person, or like how they can get over that? Or
what if we turn that into a case study of, let's put an age to this individual and say, hi, I'm
18.
Oh, okay. I'm an 18-year-old female with low desire. I don't have the urge, and like, which is basically what you did. Sorry, Rita, I just cut you off.
Yeah, so this person is 18 and their partner is 22, and they just feel no sexual desire, which I feel like during that age group you would have a lot more compared to like somebody like older when it kind of decreases. Do you have any advice for?
Well, I would want to know a lot more information. I would probably ask that person, like, how long has that been going on? How long have they been in a relationship? Has that person always felt a lack of desire or a lack of attraction to that partner? Is this something that like started happening more recently? Trying to figure out like, is there something we can attribute it to? Mm-hmm. Is there like a trauma within the relationship? Sometimes that can like cause it if a partner cheats or if there's like something traumatic that happens in the relationship. Trying to piece that out.
They say that they're not sexually attracted to anybody.
Not sexually attracted to anyone. Yeah. Okay, so that person maybe is asexual.
Okay.
If they don't have any like desire or interest in sex with any person, there is such thing as asexuality, which maybe that's something that they could try to figure out with a provider too. Mm-hmm. But that would, someone who's like asexual and doesn't have an interest in sex might still have interest in relationships. So they still might want to like be in relationships with people. They're still interested in that like attachment piece, but just don't want to be sexual.
Yeah, that makes sense. Yeah. So just finding out like what your sexuality is. Like maybe that's what.
Yeah, because I didn't hear that part, but I was going to ask like, do they have attraction to other people and it's just their partner? So assessing all that. But if there's like no attraction to anyone and they've never had that, then I would wonder if they're asexual.
And like, would they go seek therapy for that? Go talk to their like, what would their plan?
I would say for this person, that makes sense just because they're talking about that it's causing distress, right? Mm-hmm. In the very like, beginning, it was like
they're failing and causing arguments.
That part, I would think therapy would be really helpful for like, let's try to work through that piece, like reduce some of the distress, some of those feelings, work on some of the relational issues.
Yeah.
Sometimes education about asexuality too could be helpful.
Yeah, that's perfect. That's the only one I found on Read Reads, but like I thought that one was important.
Yeah.
And I thought it was just interesting that it was a younger person. Mm-hmm. Usually I feel like you hear that more with older people, but yeah.
I feel like segueing on that, there's it's kind of funny how these medications are not blown up like I feel like Viagra is, but I think it was like 2015, the study started coming out. In 2019, the FDA approved Adi and Vyleesi. These two medications are like the Viagra for women, and they are approved for like low desire, and the Adi medication was actually used to treat depression, and it was a similar thing as Viagra, where they're like, oh, this is like improving sexual desire, and we're getting these like positive results from this. And so now it is approved for that, where like it's meant to be taken before having sex, and it will increase the like desire to have sex. And then the Vyleesi medication will do that, and then in addition to that, increase arousal during sex. And yeah, so those medications are available.
I feel like you don't never hear about. Yeah, it's just the Viagra. That's like what everybody. Yeah, exactly. I was honestly gonna ask that. Is like, is there something for women that struggle with this? Oh,
okay. I got some fun facts.
I love that smile, dude.
All right, so post-sex sadness is a thing. Is that true, Toni? Don't you love my fun facts?
I don't know if that was a fact or you asked a question.
Him trying to say, guys, post-sex sadness is a thing.
Right, Toni?
It's called postcoital. Why did I say that so funny? Postcoital dysmorphia.
Interesting. I've never heard of that.
Okay, it might not be true, Google.
Well, maybe it is. I don't know.
Might have to. You have to look into that. Sex can increase. I haven't talked the whole time. Sex can increase pain tolerance.
Yes, sex, during arousal, your tolerance to pain is much higher. So, like, if you think about like some people like nipple stimulation or something like that during sex, you can pinch your nipple much harder during sex and be able to tolerate that versus like if I were to do that to you right now, you'd be like, ow, but it can be enjoyable in the moment. And so sometimes like those sensations,
I've actually heard that before. I used to watch The Man Show growing up on Spike TV. It's not a thing anymore. Yeah, but like if you're under immense pain, you just think about like having sex, and your body just naturally like has a better pain tolerance, which kind of sounds on par with what you guys were just talking about. So that just popped right in the brain, right in the dome. That's true.
I got more. Sex or orgasms can help your creative mind, creative thinking, and problem solving.
That makes sense. That checks out.
After you have orgasm, you just Picasso it up. Just all of a sudden, you just
I hit a plateau. You get writer's block.
Writer's block. You just rip one out real quick. I'm surprised we didn't talk about this. Masturbation. If this for people with penises, having orgasms can help prevent cancer, prostate cancer.
I heard that too.
Is that true?
We don't have the research on that. Now what?
This is great. That's why it is a good Joe fact, because now Luke.
Well, what orgasm can do is it can improve sleep. We talked about that in the sleep podcast. Mm-hmm. Like having sex to an orgasm will increase your quality of sleep. Increasing sleep quality will have the millions of effects. Go listen to those podcasts if you haven't yet.
Sleep one's good.
That could decrease your risk of cancer in general. So in a roundabout way, but as far as I'm aware, there haven't been any like direct studies of like.
Okay.
Wait, did you say prostate cancer?
I think so.
Specifically?
Yeah, that's what I said. Yeah.
Because that would be interesting of like considering the ejaculate has to go through the prostate. There could be something
cleaning it out.
I don't know. I'm not aware of
your
any.
Sperm is like a cleaner.
Your sperm's a cleaner.
Like Mr. Clean.
You can also have like refractory ejaculate where you like ejaculate, but it goes backwards. Like you don't actually like cause you can't fire across the room. Yeah. Anyway, continue.
Okay, so here's all right now. What do you think the longest orgasm is for a
like how long it lasts,
woman?
Or?
No, this is like
4 hours.
A stat.
4 hours.
Like the longest orgasm ever happened
Continuously?
or ever occurred for a woman?
Yeah.
Is what you're asking.
Oh.
Okay. I remember seeing some like crazy like YouTube or like not a commercial. It wouldn't have been a commercial. It was like a TV thing. Like one of those like random like this individual is hoarded their entire life. And you like look at how much stuff. I think there was someone with like this like constant orgasm. Like that was a thing. Oh. But anyway.
24 hours.
24 a whole day.
It's called persistent genital arousal disorder.
That was a Grey's Anatomy episode.
Yeah, like I know that like exists where people will have like unexpected orgasms and like
this one kind of goes with it. How many orgasms in an hour somebody had?
Like
a woman,
record?
another woman.
30?
Try again.
60.
More?
60?
Yeah.
Try again.
Oh yeah, up or down? 47. Yeah. Oh.
134.
Wow.
Hey.
Jeez.
All right, this is the one. The longest ejaculate distance.
Nice. Are we going meters or
and speed?
Oh my gosh.
Velocities in there?
Are we doing metric or feet or
feet?
Okay.
10 feet.
10 feet. I'm going to say 4.5 feet at 3 feet per second.
10 yards.
18 feet, 9 inches.
Oh.
And the speed?
Strong ejaculate.
The speed
was probably like 20 feet per second.
They got one of those speed guns?
42.7 miles per hour.
Ouch! Dangerous.
No
That'd be like an airsoft gun pelt.
Way.
Holy cow.
That was Joe's fun fact.
Wow. Thanks, Joe.
Wow.
All right, so let's come back to your practice. Like, tell us about your clientele and the approach that you take with these individuals, and like, what do we know about people who are acting out inappropriately sexually? Like, what are the most common issues with those individuals, and how do you approach it?
Okay. So the last 5 years I've been working with like adolescents and older teens who've acted out sexually. So a lot of the approach to working with them is like education, educating them about consent, healthy boundaries, the laws, how to practice healthy sexuality. So it's a lot of the things we talked about today because they just don't have that education and understanding. Then we do a lot of examining offense dynamics. So trying to understand their motivations for acting out sexually. What needs were they trying to meet? We approach sexual acting out from a good lives model perspective. So that's basically like we as humans, all people, have the same primary needs that we're trying to meet throughout our life. We can either meet those in healthy ways or unhealthy ways. And so the idea here is that sexual offending is a way to meet those same needs, but doing it in just unhealthy ways. So we're trying to understand the needs people are trying to meet, and then we're trying to teach them how to meet those needs in healthy ways. Does that kind of make sense?
Yeah, totally makes sense.
I would say that's like, in a nutshell, the work that we're doing.
And is it effective? Like,
yeah.
And
well, recidivism rates for adolescents, for sexual recidivism rates for adolescents are super, super low. Some studies show it as low as like 2%. So
what's recidivism?
Like reoffending.
Oh, okay.
The percentage of people who reoffend is super low.
Okay. So there is an effective.
But that's even like without treatment. Most of the time, young people who are acting out sexually aren't going to do it again. Or if they are reoffending, it's going to be in like non-sexual ways primarily. So.
Sure.
But I think it's effective. I mean, we track outcomes for our program just in terms of like follow-ups, 5-year follow-ups, how many of our clients reoffended. I don't have that data in front of me, but how many reoffended sexually, non-sexually. But we'll also track risk reduction. And I think our last outcome was like 80% of the clients we worked with completed successfully. There was a significant reduction in risk from when they entered programming to when they left programming. An increase in skills around self-regulation, education around sex, all those things.
That's all interesting. Now, with somebody who is leaving prison and going to this like residential area, like, is there now, like, are you working towards a transition process to get them out of that residential facility? And what does that timeline typically look like? So I'm going to speak a little bit about like my previous experience in residential because we haven't had our first clients yet in the new program. Sure.
Interestingly though, like Alpha Human Services, which is where I started my practicum, I worked there as a therapist. That's the residential. Our current program at Steps for Change is the exact same house that was bought. So I'm doing full circle with my career, but that's like the only city, county, like government approved location in Minnesota where they'll like allow a residential. So it's exact same location. Those people, so right now this used to be like a 23 person residential program. The new program is only 7, so significantly smaller. So the clientele that we're accepting, we have to be we're much more limited in who we can take. And so Department of Corrections wanted those beds to be reserved for like the highest risk people. So primarily the people that are coming in, they're going to be assigned a level 3 sex offender. They're, may have prior failed treatment experience. They might have reoffended in the community. So typically they're like more higher risk than people who would definitely be in like an outpatient setting, but maybe people that I worked with in the old residential program, just because we don't have the capacity for as many people. What that program is, so we have our estimate for in-house, the residential part would be, I think, 13 to 15 months. And they move through different phases. Each phase of treatment has different goals. So when they first come in, we're doing huge assessments like personality inventories, risk assessments, social history information, psychosexual history information. Like, it's hours and hours of interviews to get all these histories for people, trying to figure out treatment area, like goal area focuses. So assessment's a huge piece of treatment, getting to know them and just their histories. Educating them is kind of similar to adolescents, just educating them about sex because they typically don't have that education. Another phase is examining their offense dynamics. So just like with the adolescents, we're wanting to understand why they've engaged in criminal behavior before. With adults, like there are differences between working with adolescents and adults. We don't predict risk with kids just because that recidivism is so low. It's like statistically insignificant if we're predicting risk on a 2% recidivism. For adults, we do predict risk. We would say like this person is at a high risk of reoffending based on different assessments that we use. Sometimes for adults, in my anecdotal experience, they can have a lot more ingrained cognitive distortions just because they've had a lot more life history of offending. So there's like those built-in distortions of like people ask for sexual, like if they behave in a certain way, if they dress a certain way, that they're like looking for sexual attention. Sometimes if they're being sexual with children, there's a lot of distortions around the kids like enjoying sexual contact, asking for sexual contact. So there's a lot of like distortions and enmeshed thinking that we really have to pull apart. I'm kind of going off on a lot of side tangents, but
that's what we do here.
That's what we're all about.
Other parts of treatment are like building empathy, perspective taking skills, doing a lot of their own work around like self-esteem, values, because a lot of people experience intense shame for their behaviors, or they have like really significant past traumas that impact them. And so we're trying to work through those. And then the last phase is like all about transition planning, reintegrating them into the community. How are we going to do that safely? So there's this built-in part where we're kind of helping them plan for jobs, plan for independent housing. And as they're transitioning in the community, they're still participating in therapy. So we can kind of check in with them on like how that's going. Does that answer your question?
Yeah, that answers my question and then some. I just like picturing that setting. I would have such a hard time getting rid of my own biases towards these individuals. I have no idea. Like that, like how do you do that?
I don't know. That's what everyone says. Yeah. People are just like, oh, that must be such hard work. And to be honest with you, it isn't for me. I think it's really easy for me to have empathy for the people that I work with and just the experiences that they've gone through. I don't think that there's anyone that I've worked with that hasn't had some sort of trauma in their life. And so it helps me to just have empathy for that experience. Like I can connect on that human level for like what they've went through and experiences that they've had. It also really helps if they're like willing to take in feedback and like willing to work. I think for me, my personal like bias and struggle is for people who just really like don't think that they need to do anything different. They're not willing to work to change, and that can be much harder. As long as people are willing to say like, yeah, what I did was fucked up. I don't like it. I want to learn how to do things differently. I can always work with that. And
what would you say the percentage is, like people that are willing to make a change to not like 50% or less than that?
Oh gosh.
People that are willing to change?
We're actually going to be collecting data on this for our quality assurance for people coming in on their states of change. So I'll be able to have an answer to that in 5 years when we get that research back. But I don't know. I would say like a majority of the people I work with, we can get at least some common ground on something they want to work with just to get the buy-in. Maybe it's not about their sexual offense right away. Maybe they're like, I just have a lot of anxiety, or I have a previous experience with like physical abuse, or my relationship is suffering. And we can agree to like work on those things, and then I can at least get some buy-in from them. We can build trust, we have a rapport, and then I can start to say like, okay, let's talk about your sexual behavior now, because that's, you know, ended up in you being here, and that's going to impact so many areas of your life and your health and your well-being. So like, we got to talk about it. We got to address it.
Yeah. It's good to know that those places and people like you and facilities like that exist, because I had no idea until you became my sister 30 years ago.
Do other states have similar programs? Are we like the first to do this, like have a house for them, or are we kind of late to the game?
In terms of like residential outside of prisons, I don't know. I don't really know of any.
Outside of prison to kind of integrate them into society, make sure
I
they don't
know that
reoffend.
the residential programs are pretty rare.
Pretty rare. Okay.
Yeah. Outside of like prison settings. Okay. I don't know off the top of my head like how many exist or what that looks like in other states. Though.
Okay. Just curious if that was something that was already been implemented. We're late to the game, or if like this is like groundbreaking. Like
we need more.
If this like works, like will this just take off like wildfire, and this will be good for everybody?
Well, Alpha, the program before ours, like had been in existence, I want to say like 50 years. I don't know. Like that had been a program for a long time, and there wasn't a big push for expansion. I think a lot of it is like, so you have to get like city permission, county permission, zoning. People like you guys talked about bias and stigma you have toward people who commit sexual offenses. Like think about if we came into your neighborhood and we're like, hey, this house right here, we're actually going to house 10 people who've committed sexual offenses, maybe against children, maybe against adults, all these things, failed treatment before, they've been in prison 3 times. They're going to be next door to you.
That'd be tough.
You know, people are like, no, I don't want that. So there's a lot of like resistance, I think, from communities
that makes sense.
For that.
Yeah.
Even though like registration, so people who come out of prison, they're assigned a risk level, like level 3 sex offenders, for example, have to notify the community. They have what's called community registration, predatory offender registry, where you can like look people up online. People think that that's going to keep them safer, but research says that it's really like not effective at doing any of that. And it's really super harmful for the person who has to register. They're not able to get certain jobs. They're not able to get housing. Like it's really, really restricting and limiting. And it just prevents them from like living a healthy life in the community.
Yeah. I could see that being like a slow moving field. Hi, Kato. Hi, buddy. They need like a German Funkendonkel trial.
Actually, Patty Wetterling, if you guys remember like the Jacob Wetterling. Patty Wetterling speaks at our conferences almost every year and pushes for getting rid of registration, which people would think like, wait, her child went through this, like, and she's advocating for people to not have to register, and she's really important to our field too.
Interesting.
Yeah.
What other, so before we like summarize stuff, like what cool areas of research just in sexual health, like any other updates that are super interesting or that you find fascinating within the field?
One thing I was going to talk about today, but we kind of didn't have time, in an area of research I'm really interested in is Dr. Debbie Herbennick's research out of Indiana University or University of Indiana. I'm not sure which one. And she's looking at just kind of like different sex trends in college populations right now. And what she's finding is like the prevalence of a lot of rough sex in college students and even a lot younger. So like choking is a huge one. And I was like very surprised to see the prevalence of how often that's happening. And I think the big takeaways that I've gathered from her research are like these things are happening with younger and younger populations. Like people report first experiencing choking at age 13.
Jeez.
And choking is kind of like not the right term, right? Because choking implies that it's something inside your throat or esophagus blocking your airway. What we're actually talking about with the hand on the throat is strangulation, right? But we're saying choking because that's kind of how society is defining it, how it's showed in pornography, how it's showed in the media. So like people very young are reporting engaging in that behavior. And I think the most significant thing for me is that they're reporting that that is something that's done to them without talking about it first, without consent. A partner is just choking them sometimes during kissing, sometimes during intercourse, and it's nothing that's discussed. And then people are reporting a lot of different, I guess, like, I don't know what we would call it, reactions to that. Like after being choked, sometimes there's a loss of consciousness, there's dizziness, there's lightheadedness. I mean, lots of different things happen when we're restricting air, and that can be really significant too. So that's been a really interesting area of research to me, just to find how like sex trends are changing and how what we term like rough sex is becoming much more the norm. And just, I want to make it clear that like, I don't want to kink shame. I think that choking can be a really like, cool, you want to do that in your relationship? Awesome. However, that needs to be done safely. People in like BDSM or kink communities are really great about having conversations around those behaviors, getting consent, talking about like, how would I know if I'm crossing your line, and safe words and all that stuff, so that they're being safe. And what this research is showing is that this is happening in populations of people where they're not practicing any of that. They're not getting consent. They're not talking about it first. They're not talking about it afterwards. And then the students who were talking about experiences with choking, a lot of times afterward, they're saying things like, I really didn't like that. It made me feel unsafe. Or even the person doing the choking was like, I made a partner pass out, and that really scared me. And they liked it, but I really didn't. And so there's all this like crazy stuff around that, yeah.
Wow. That's interesting. And I wonder like how much like social media and things like that is influencing it.
So I've listened to Dr. Herbenek or Bennett conferences and workshops where she's presented on her research. And there was one conference I attended where she was just showing all of the like social media stuff, like GIFs and images and all those things that talk about choking, and all these really popular TV shows and movies that are showing it. So it's really normalized for young people, and I think that is a huge factor. They don't show, well, and porn is another big thing, but they're not showing how to safely engage in that behavior. And then people just think you're seeing it in porn and you think, oh, people really enjoy this. Yeah. It's a lot of like male-bodied people doing that to female-bodied people, and that's what you see in porn. And yeah,
you could see the like adverse effects, which is, I think the word with reaction, you're saying like there's like harm
neurological.
Yeah, I mean you're depriving your brain of oxygen.
Yeah. And if you think about like how often people are reporting engaging in that, if you're like losing consciousness and that's something you do every time you have sex, like what long-term impact is that going to have?
It's kind of like that space monkey thing, you know, people like, they would like purposely, like kids would do that when we were in high school. Like they would just like choke themselves out to like pass out. Like that's scary. Like, kids died from that.
Yeah.
Like, super scary.
Yeah. Trends are crazy.
So if that's what you're into, just do it safe.
Yeah.
So definitely that's the new thing. I mean, it's good to be aware of those things. Mm-hmm. And like,
again, for like parents talking to kids and letting them know, like Dr. Herbenek said that for her young kids, she always talks about like safety with the neck, like always making sure if our kids are roughhousing that they know do not ever put hands on people's necks, and talking about the danger with that, just kind of like how we introduce kids to that stuff too.
Interesting. The world's a crazy place.
Yeah. It is a crazy place.
Any other topics that you wanted to bring up before we summarize? So in like my view of the summary, and like the message that I think we did a really good job of sending in this podcast with having you on and talking about these things, is like to just drive home the point of this is a component of your health. Like your sexual health applies to every other aspect of your health. And if you don't have if you have a low sexual health, like that's going to contribute to poor mental health and physiological health. And just knowing that there are so many different things you can do for all these different sexual dysfunctions. You just have to make the right people aware. So like sex therapy, couples therapy, go to your physician and bring these things up, or even just talking about it with your partner and being open about these things. And like, that's going to have such an impact on so many other aspects of your life. And then also just a little plug for like, you look at the research of exercise and what that does to sexual function, especially with age. Just get out there and be active, right?
Yeah.
Pick some stuff up, put it down.
Pick some stuff up, put it down.
Penis push-ups.
Yeah, penis push-ups.
What's your summary takeaway for everybody?
I think that sums it up too. Sexual health really impacts every single area of your life. Maybe too, like if you are experiencing some type of sexual dysfunction, like normalizing how common that is and recognizing that like there are a lot of things that you can do that doesn't have to be impacting you negatively forever. Like you can work on that. Yeah.
And that you should work on it.
Yeah.
Like you should go get these things figured out and get help and do that, because it's gonna have an impact.
And that in general, we like don't talk about sex enough and we don't educate people about sex enough. And so just trying to like create a dialogue where that can happen so people feel more comfortable.
Yeah.
Any more fun facts, Joe?
Oh, should we play the boner, how the boner grows song?
Ask your question.
I do. Before we end, I do have a thought-provoking question, though.
Okay.
I don't know if it's top tier, but I found one. I like this one a lot.
Why do you always preface with that? Just say it.
Because
now I'm going to think it's not top tier.
I know, because I know. I'm just downgrading it, so then you're like, oh, that was a good one. Reading, I'm like, oh. Would you rather lose all your memories or never be able to make new ones?
Joe's going to answer first.
Joe looks like he's ready for this one.
What was it? Would you rather
lose all your memories, like all your past memories, or never be able to make new ones?
That's
a tough one.
Yeah, because like there's a lot of good old memories.
Yeah, like wedding day and stuff, but then like.
But okay, wait. So wouldn't new memories be old memories?
That's what I was just going to say. I think my answer is I would rather lose all my previous memories.
Yeah.
Because then with forming new memories, I could be like, yo, what was I like as a kid? And then like looking at pictures and looking at that.
That's
and
exactly what I was going to say too.
Like, yeah, for sure.
All right. Yeah, cool.
So we're kind of all on. What do you think, Toni?
Yeah, that makes sense
So
to me.
we'll lose all our old
I
ones.
was going to say that I would want to keep my old memories though, until I heard your guys' explanation, and then I agree with that.
If that were like a line of like, you can't know anything that happened prior to this moment, then that would change things.
Let's do that. Let's like, you can't relearn anything old. You can't ask that question. You have to just go from now on.
But wouldn't every day be an old memory at the end of the day?
Well, yeah.
But it's starting from like today.
From like starting today.
Today, you can remember everything going forward, or you can't remember anything, and you can't go back or learn anything from your past. What would you rather do?
I still got a lot of life ahead of me.
Yeah, right.
I'm gonna remember new things.
I still keep
so
my
too.
new memories. I think I'd keep that one.
Yeah.
All right, now look up the boner song.
I got it.
You
got it?
Yep. There's a video to go along if you're interested.
Joe, you could
This
literally
is
just
from-
put it in the podcast
This
too.
is from amaze.org. This is where we like to like refer parents for like how to educate kids around sex, because it's like developmentally appropriate stuff. Oh wait, I have my audio.
Allie's probably like, what the heck is going on?
It's normal for guys to get 4 to 5 erections per night.
Hilarious. Tell me I'm not alone. Pushed over the sandcastle.
James up a car. Professional. My equator grows another pole.
Not really a bone.
Fills with blood.
Sounds like Green Day.
The next video coming up, masturbation, totally normal. That's incredible. So that's gonna be the new kids song.
Let's go tuck our boners in our belts.
Tuck our boners. All right. Well, thanks for coming on, Toni.
Yeah, thank you, Toni.
This is.
Yeah, thanks for having me.
I think this is gonna be a cool topic for people. A little change of swing here, but also totally applying to the underlying kickback science concept.
I was a little nervous coming on today, not gonna lie.
Because we're talking about sex.
Sex is just something that I don't really talk about.
Yeah.
Nor does anybody talk about, but feel better.
Now we're gonna share our discussion with the world.
Yeah.
I'm gonna miss you guys.
I miss you guys too.
Thanks again for tuning in to the Kickback Science Podcast. We love talking science with all of you, and if you feel the same, you can support us by subscribing, hitting that like button, and giving us a follow on our social media pages. Don't forget, you can submit questions through our website and in the comments section of all our social media. Have a good one, everyone.